Well, as we saw in last night's debate, no one has easy answers when it comes to curbing healthcare spending. Wall Street Journal senior editor David Wessel has written a book on the subject, and he joins us now. David, I want to get to you. Healthcare is really by far the largest obstacle when it comes to getting the deficit under control. I mean, how big is the problem really?
Right. Well, when you talk about spending in the federal budget, you cannot do this you cannot have a coherent plan without doing something about healthcare spending. In 1960, healthcare was 9.5% of all federal spending. Last year it was 25%, and the Congressional Budget Office says it's on track to get to 33% within a decade. It's simply the government is covering more people, partly because so many more people are turning 65 and joining the Medicare program. And healthcare costs go up faster than almost any other costs in the economy.
Okay, and you say in your story that about 25% of Medicare spending is done in the last year of patients' lives, but and mathematically that would seem to be a place that would have to be cut, or no?
Right. So 25% of Medicare spending, according to the most reliable estimates, is spent on the 5% or so of Medicare beneficiaries who die every year. And people have this sense, and it's intuitive, and you can see it, that there's just an awful lot of excessive care at the end of life. And if we could find some way not to do that, we'd save money and we'd be all better off. There are a couple of problems with this argument. Just because there's a lot of money there doesn't mean there's a lot of savings there. It's not like someone shows up at the hospital with an expiration date stamped on their rump and says, this person's going to die in the next 4 weeks. Don't treat them. A lot of the care that's given at the end of life is given because the doctors or the patients think it will extend or improve their lives. It's hard to distinguish. Third, we don't really have a good way to turn off this end-of-life spending. Living wills, advance directives, hospice care, they're all good things to do. People should have the right to choose the way they die. But the evidence is that these don't actually save very much money, at least so far. So the point of my column is to say that we probably have to look to somewhere else in the healthcare system to save money. Doing it at the end of life. Well, I think there are lots of places to look, and the 2 points that I think are most important for people to know is, one, we have the world's least efficient healthcare delivery system. We have to change it. Okay. Mitt Romney and Barack Obama both agree with that. They just don't agree on how to get there. And also, Medicare spends an extraordinary amount of money, as does the rest of the society, on caring for people who have a lot of chronic disease. And that is something that our system is not equipped to deal with. We've trained doctors body part by body part. We pay doctors and hospitals for services rendered, not for the outcomes. And we have a very fragmented system that doesn't coordinate the care for someone who has hypertension, diabetes, arthritis, and respiratory disease. And these people are very expensive. So I think that's one place to look where we could organize care differently and think of ways to treat people who have multiple chronic diseases, many of whom do not die in any given year, so the spending on them goes on for years and years and years.
Okay, now, will coordinating care, will making the really delivery of health care more efficient, does that necessarily solve the problem? It sounds to me like when we're talking about certain conditions, certain chronic conditions like diabetes and obesity and these things that lead to higher health costs later, I mean, what we really need to do is change behavior, but is that something that the government can really influence?
Well, you're absolutely right. I mean, obesity and smoking are great examples of things that we know contribute to healthcare costs, shorten life, make people sicker, and people have to decide what to do there. But it's not true that there's no ability to affect the cost by making the healthcare system more efficient. 2 examples. One is, if you know that people are more likely to exercise or to watch their diet if they're on diabetes, if they're getting frequent calls or checkups or some kind of electronic monitoring for their doctor, they may be more likely to take the steps that save us money in the future. It's not going to be easy. But secondly, when you have multiple chronic conditions, you often get competing advice from different doctors. One doctor is the heart specialist and he says this, someone else is a liver specialist and he says that. And so not having it coordinated means that there's duplicated tests and there's conflicting advice that leaves people very confused. It's not a silver bullet. There is no silver bullet to slay the dragon of healthcare cost spending. Okay. But we know that we spend more money than any other country in the world per capita. We don't have the healthiest population. We have to find a way to change that.
Okay, and I got to direct readers, who want more information, don't just read David's column, read his book that's just out. Thank you this morning. Thank you so much for coming in, David.
You're welcome.